You've tuned into Radio Northern Beaches. We live stream on rnb.org.au across the northern beaches of New South Wales, Australia and all over the world. You can also catch us local on 88.7 and 90.3 FM. Our podcasts are available at your convenience at rnb.org.au or rnbpodcast.com.au. So you and your friends don't miss any episodes. Don't forget to follow and share. Now here's our latest podcast.
Welcome again, listeners, to Community Radio Northern Beaches, 88.7, 90.3 FM, streaming live on our website, www.rnb.org.au. This is Community Voices. I'm Michael Lester. We've talked before with our guest today about crisis in aged care, which has been running for a long time now in Australia, not least in the wake of the Royal Commission on Aged Care in 2021, which reported huge underperformance, neglect, abuse. We now have in front of Parliament under the new Labor government proposals for a new bill for aged care, which some people want to characterise and seem to characterise as the needed radical reform we need to the system, both in the way in which it's focused and operates, but also on its financing. Even today in the papers, we see that newspaper headlines along the lines of aged care bed shortages as funding crisis worsens. To discuss these issues and the nature of the problems and challenges faced by the sector as the population ages, as we all know, I'm pleased to welcome again to our program Professor Joseph Ibrahim at Latrobe University and at the Centre for Evidence-Based Aged Care and the Institute of Primary Care and Ageing. Thank you very much, Joe, for joining us again.
Thank you, Michael.
Joe, the Royal Commission particularly pointed back in 2021 to a lot of neglect, abuse, and not good care or quality of care. And this was highlighted, of course, during the COVID period subsequently. I believe that the new proposals for reform is what's called a rights-based approach. What does this mean in terms of the way that the aged care sector's operating or been operating, and how does it be different to what perhaps is the basis in the current Aged Care Act legislation?
That's a very, profound sort of question, and it might be a bit tedious for your listeners, but it goes back to the term of what do you mean by the term right? And people tend to assume that a rights-based approach is one that is fully and completely respects your human rights, which then entails your legal and healthcare or social rights. So I think what we want to do is to be very careful when you're talking about rights-based, is to just ask the question about to what level is it rights-based and what is it protecting. Now, the new legislation is important, and it's important that we progress from the 1997 Act. The fundamental issue for me is that while the government has called it a rights-based, I would argue that it's not a human rights-based act or bill that they've prepared. And by that, I mean very simply is to have a look at the National Convention of Human Rights and then to measure the bill as it's written as to how well does it conform to or adhere to that human rights standard. I'll give you two examples where, in terms of human rights, that there's a human right not to be tortured. Restrictive practice is a form of torture. And so the new act does not remove restrictive practice. What it does is it, in a sense, institutionalizes it, calls it a last resort. But again, we run into problems about what's considered a last resort. So in terms of a human rights-based bill, I say there's one example where it's failed, and we should have really been looking at a bill that was designed to provide the conditions where restrictive practice was eliminated. That's one area that I think needs more work and consideration. The second example is when you're in aged care, you're capped, especially in residential aged care, and you sign a contract, you're captive to that system. So you don't necessarily have the same level of consumer or other legal rights that you would have if you're in the community. So you, in a sense, are signing up to a closed system of arbitration with limited capacity to pursue your, I guess, compensation or redress for things that have gone wrong. And we've seen that with the funding issues where the Liberal Party agreed to a bipartisan approach once the ability to litigate against providers for poor care was removed as a condition. And so, again, when people are talking a rights-based bill, I would say this is a rights-based light, if you want to use sort of the common parlance, that it's not a fully rights-based bill. But on the other hand, it's going to be better than what we used to have.
I believe that to give effect to some of this, based on some of the points you're making, that they propose to have a statement of rights and principles, presumably for the first time, although I understand too that many of these rights that might be stated are not even apparently going to be legally enforceable or in the courts. So as you say, it's rights-based and it might be better than it's been, but not. Presumably one of the reasons for this reform flows out of all those abuses and lack of care, whatever that was available and revealed by the Royal Commission. But the other reform area really is in response to what was the marketisation and privatisation effectively of aged care in the 1990s under the Howard market-based reforms. I believe there are some elements in this new framework that are designed to get a better result with standards and quality and safety and regulation in that regard.
I'm just going to go back a step just to address the question about, do you believe that you have rights if those rights aren't enforceable? People really need to be very circumspect and to be asking questions about what are our politicians saying and what do they mean? What's behind it? So it's very easy to get fooled or blindsided by simple repetition. And the repetition that this is rights-based makes everyone think that the problem has been solved because what we've now got is your rights are being respected. But I've given two examples where your rights aren't being respected. The government's been transparent pretty much in the bill that they're going to give you a set of rights that are not enforceable and that you cannot, I guess, litigate to enforce them. So that's just window dressing. And yeah, aged care is not at a stage where we need to worry about window dressing. We've actually got to be worried about it's not the window dressing. So it's not that we've got everything right and now we're just looking to make it look a bit more stylish and glam it up, is we don't have the fundamentals sorted out properly. Now, the focus on improving quality of care is important. And again, that's being strengthened. But the inherent problem with the accreditation system, and this is not unique to aged care in Australia, it's a problem with all accreditation systems, is it's only able to determine whether the bare minimum standards have been met. And the minimum standards are not what make your life good. It's what is the minimum that you'd expect. And so good care is different to minimum standard care. And so I think that while the minimum standards may well be raised, it's still not at a level that I think is worthy or appropriate for care of people. And I think it's better that we talk about people rather than older people, because the minute we talk about older people is ageist views come into it very quickly and we tend to compromise about what's acceptable. So the new bill does advance that, but not to a level that is possible in contemporary society. The fact that you don't have ready legal redress, the fact that they're not applying a human rights framework to it, to adhere to the international convention, shows you that we are missing the bar. And we could have had a far more aspirational and a far more, we could have set the standard internationally with what we did with this bill, but we haven't done that. We've compromised.
There's also a proposed new regulatory model, I believe, with the establishment of a commission to enforce this. I believe that this whole thrust, from what I read, has been resisted and rejected by carers and providers in the sector. What is proposed in terms of this enforcement and regulatory mechanism that might be different to the way things have operated before?
I'm going to have to confess here, I'm not certain about how different it's going to be. So we know that there's the star rating system. Well, the fundamentals, there's two areas that I think are worth contemplating. Let me just talk about the fundamentals of assessing quality of care using the regulator is that you have a set of standards and you have a set of performance measures. Each of these have their inherent limitations no matter where you are. And in terms of enforcement or regulation, you have sort of the soft or light touch model of regulation, whereas you go in, assess a place, and you say, you're not up to scratch. We need you to pick up your game, and you've got a week, a month, a year to address it. Those fundamentals I don't think are going to change. They might be quicker at telling people where they're falling down. They might want action sooner. They might want more evidence of change, but I don't, and that sort of tightens up a system that is in the end bound by the existing rules in the bill, which again, I come back to because I think it's failed on the human rights level, doesn't lead us to that very high standards of care. The other is that we have in a sense, a captive, the government, the regulator, and the providers are captive to the one system. And so they're the three major players. The government needs the aged care providers to provide the service. The regulator is charged with ensuring standards appropriate for contemporary society and is funded by the government. And the providers got to run a business, which means they've got to follow the rule. But there's a high level of interdependency within those three. The resident really doesn't fit into that. The resident's almost got no power at all in that situation. It might seem that they do with anecdotal cases, but overall, and as a force for change, the residents do not have the same level of power. And so what we have is a compromised system where, because of those interdependencies, and so you're almost always looking for a compromise. And whenever you're looking for a compromise, it usually means you're not going to achieve the best that you can. And what you're going to end up with, what we call regression to the mean. You're going to come back to what on average is acceptable to most people rather than what is exceptional.
Community Voices today is Joe Ibrahim. He's the professor specialising in aged care issues at Latrobe University, and we're talking about the proposed aged care reform proposals that are sitting on the table in Canberra for legislation this year in the wake, 3 years later, of the Royal Commission report. We're talking mainly here, I think, in the first instance about residential aged care, but we're also talking about Commonwealth-funded care in the home and home care support, but also hospitals play a role. And each of these three components in responding to aged care and needs have different dynamics and economics and structure, don't they?
They do. So in contrast to what I've described of a heavily interlinked relationship between government, the aged care providers, and the regulator, what you have in the community is it's uncoupled, which creates, I think, a much greater level creates far more gaps in the system, far more inefficiencies, and each is contained to their rules. They're bound by the limits that they've got. And so a hospital behaving flexibly in supporting older people is not going to be rewarded if it is taking stress off the aged care system. And the aged care system is not rewarded for taking pressure off the healthcare system because they operate in very clear silos with different funding rules and different performance measures or metrics. And so this limits the ability for innovation. It limits the ability for seamless flow between one to the other. And it just makes things far more difficult in terms of accessing services. And so the Royal Commission had made recommendations on better coordination and integration of medical and allied health care and availability and better integration of the healthcare system. But these were the recommendations that were the ones that were under consideration by government and not acted upon. And I don't see that the new bill is going to actually address that.
The structure is very complex and there's a lot of shifting around. And just from a finance and economics point of view, as we say, there's a funding crisis in the residential aged care sector, obviously. Big numbers are being quoted about most operators running at a big loss, 70% of them running at a loss and needing to shut down, and billions of dollars in the black. Meanwhile, it costs a lot more, doesn't it, to look after someone in a hospital per day than, say, it does at home, which presumably too is cheaper than residential aged care. So to the extent they're shifting and a non-optimal balance for whatever reason has huge financial implications. If we could turn, though, to the finance situation in the residential aged care sector, I believe that the range of providers there, that 85% of the budget of this sector is provided by the government, with the balance provided by consumers. Is that right? And what's the dynamic here of Commonwealth government funding?
The general description you've given is correct, that the vast majority of money that goes into residential aged care is from the government. There's additional money that comes from the residential bonds, and there's additional money that comes from extra services that people might wish to purchase from their aged care provider. So the vast majority is government funding, as it is with schools, as it is with police, as it is with healthcare.
Even though this has private operators delivering, doesn't it, as distinct from government provision. And apparently, according to the Federal Government Task Force on Financing, that's the sector that's just reported, the sector seems to be needing a huge injection of tens of billions of dollars of extra public money, or else the sector says they're going to be closing down beds.
The model of service delivery is one the government chose 2 decades ago. And in the same way that you have private hospitals and public hospitals, we mostly only have non-public funded. Most aged care providers are either private, not-for-profit faith-based, or not-for-profit, not faith-based, community-based services. Victoria has a large number of public sector funded or operated residential care beds. So the model of how you deliver services has been, in a sense, chosen. In healthcare, you've got both a public hospitals and private hospitals. The private hospitals are still publicly funded from the government through Medicare and with subsidies through to the private insurers. You know, things get a bit trickier, but the federal government is still making contributions into healthcare wherever you get it. And I labour that point because I'm trying to get people to understand that it's not the user who's paying in these other areas. The same thing applies when your child goes to a public school. And if your child goes to a private school, the government is still contributing to the private school. You are as well as a user, but the user at a private school is not the sole source of funding. And so the question about, do you need tens of billions of dollars more? And the answer is generally no. You don't need another 10 billion plus currently, and it depends again on how you're doing the sums. aged care funding has increased from, let's say, about, and these are approximate figures, so they're just sort of ballpark, let's say around 10 billion and gone to around 20 billion in the last 2 decades, and will probably approach 30 billion by sometime between 2025 and 2030. What we don't know, and these are questions I put to, is why are there still private operators in the sector if people are losing money? That question's not been answered to me. So if you're a private operator and you're losing money, how is that possible? And in terms of prudential regulation, you're meant to be financially viable to exist as a private company. And so if all of the aged care providers are struggling financially and are not viable, then ASICs ought to be, we ought to be hearing more from ASICs, and we ought to see more people trying to get out of the market, so to speak.
We do see reports of nearly a $10 billion so-called black hole in the operators providing facilities, although it is interesting, as I understand, that the publicly listed aged care companies, providers, are registering big profits and are buying up people, and which could be a process of consolidation. So there's a bit of a market dynamic at work here, a competitive dynamic, or not?
I don't know that competitive is the right word, but there's something going on in the market that, as a non-economic, so I'm not an economist, I don't understand. So to me, it's not making sense that there's no money to be made. People continue to operate at a loss. And I know if I wasn't paying my mortgage to the bank, they would very quickly shut me down and I'd be in trouble. So that's not clearly apparent in the sector. If I'm a private company and I'm driven by my shareholders who want to profit, why am I buying up more homes if these are not profitable? This doesn't make sense. I think that overall, the providers are correct in that there is not enough money in the system. But you have to then think about what is the money for, and the money is there to buy resources. And resources we know we need more people, and we need more people with better training. And if we've got more people and more people with better training, we're more likely to get better care. So I've got no argument with that as something that needs to happen. What hasn't been demonstrated is where is money being lost due to poor care and complications of care? Where is money lost or diverted or spent on the healthcare system that could have gone into aged care? Or where is the money that's being spent in aged care that should really the cost for healthcare, because aged care providers are being asked to do far more than they're equipped to do, and hospitals ought to be picking up some of the slack?
Can I ask you, Joe, about the funding options that seem to be being looked at in the wake of a Commonwealth task force just reported a couple of months ago with 23 recommendations on the funding, the main principle of which seems to be that consumers and users of aged care are going to have to pay a bigger share of the costs than they currently pay. Various mechanisms were looked at and apparently recommended against a levy, a dedicated tax, if you like say Medicare levy, I guess for political reasons, who knows. And they recommended against any change to means testing on the family home in terms of what people might pay. But generally, they seem to be recommending ways in which people will pay more, particularly the boomers with assets in the home, presumably, and in their super, for the services they're going to get from the aged care services. Is that your understanding of where it's going?
That's my understanding.
Do we have any idea of just how that's going to be done, and whether that's going to, what sort of results that's going to achieve in terms of both quantity and quality?
I'm not aware of it. I do not support it. I think it's an ageist policy. I think it's unfair and unreasonable, and I don't see how it's going to be sustainable into the future. I'd say it's ageist because when you're talking it's a user pays. When I have dementia and I'm riddled with arthritis and I can't look after myself, I'm not suddenly thinking, oh, great, I can now go to an aged care home and I'm going to choose one and all the money I've saved is going to go to that. The issue is that what the government is asking is they're asking for people with significant disability to now pay for care that's available or should be available to any citizen of this country. So we don't have a user pay system for healthcare. We don't have a user pay system for schools. We don't have a user pay system if you live in a high crime area and you call the police out. None of those are user pays. So why should aged care be user pays? The argument that the baby boomers have all the money is, well, maybe the baby boomers do have all the money now, but once the baby boomers are dead, all the money is gone to the next generation. So the issue of community or inequity in funding or inequity of finances or assets, I'm not struggling for the right word, is temporary. And that inequity is going to happen with the next generation. So the Gen Xers in 20 years' time are going to have all of the money that the baby boomers had, and other Gen Ys then going to say, well, this is not fair. The other point is that if you really wanted to address the problem, a levy, which is what was proposed by the Royal Commission, would be the fairest way to do it. If you wanted to address the social issue of inequity in assets, then you would design a wealth tax to do that. If you're worried about getting money into the aged care system, you can go to the other portfolios and have a look. Aged care only takes about 1% to 1 and a bit percent of our total GDP of the country. And there are far other greater areas you might be able to take money to buff that up. And what's going to happen is that estate planning and financial planning is going to design things so the baby boomers with money don't have any money when they're going to need it to go into aged care in their 80s. And so this notion that this is going to solve the problem, I'm unconvinced. And it might make things better for 5 years in terms of bringing money in, but beyond that, I don't see how it's going to be sustainable, because every 60-year-old and every 70-year-old is now going to be thinking, what am I going to do with all my assets? And I'm going to pass them off to the kids now because I don't pay.
You mentioned the reimbursable or refundable accommodation deposit. I believe at the moment, an average deposit that someone has to raise to get into these facilities is about $500,000, and up to $1 million is not uncommon. This is clearly favouring people with the wealth and the assets to contribute more. In effect, these refundable bonds are nothing more than interest-free loans, aren't they, for the providers? And I believe that the task force and maybe the bill is going to recommend even more access to that money from providers.
It's this government and both major parties have been really very, I think, gutless in their approach. And essentially what they're doing is taking money from, on average, 80-year-olds with dementia and other physical disabilities. That's who they're taking money from. And if they want to work on a user's pay model, I come back to the entire inconsistencies or incongruencies, is if I'm the user pays and I'm a consumer and I want my consumer rights and I want to be able to sue you if you're not providing the care, and I want a mechanism that protects my rights, and I want rights that are clearly enforceable when I sign a contract with you, which are not provided in the draft bill. How does all of that work?
It's a very good question, as you say. I want to thank you very much, Professor Joseph Ibrahim from Latrobe, aged care specialist and expert in aged care policy and care, joining us on Community Voices. As you say, perhaps the proposals before the Parliament for the new reforms are perhaps not as clear as they could be, and perhaps raise as many questions as they potentially answer in what's a very important area of policies. Thank you very much, Joe, for taking the time to join us here on Radio Northern Beaches.
No worries. Thanks, Michael.
Australia, the lucky country. We've got meat pies. We've got the world's best beer. But most importantly, top of the list, we've got Radio Northern Beaches 88.7, 90.3. Now hitting the entire world on www.rmb.org.au.